So now we're going into the normal newborn, and this is nursing theory and practice of that normal newborn. The neonatal period is defined of the first 28 days of life. So they're called a newborn, but they're specifically called a neonate in those first 28 days. And this is where they're actually switching from fetal to neonatal circulation. So this is a big deal that they're doing this within these 28 days. Some things that are hallmark of this is that they'll change from that placenta being the source of their oxygen now to a regular pulmonary gas exchange and fluid exchange. The next thing that's a hallmark for them is they have short-lived red blood cells. So these only live about 80 to 100 days as compared to adults who their red blood cells live at least 120 days. So they have short-lived red blood cells, and we'll talk later how the fact that these are short-lived and they break down more frequently and because of their short lives, that this is where jaundice plays a part. The next thing that's a hallmark of the neonate is they have to thermoregulate. So thermoregulation is the balance of heat loss and heat production. They do not have a shivering reflex, so a newborn cannot shiver. This is how normally people will generate heat. We shiver and it generates heat to warm us up. However, in the absence of the shiver reflex, newborns have to use something we call brown fat that is oxidized to try to keep them warm, and they also tend to use their glucose reserves as they're trying to generate energy to stay warm. And we're going to talk about this later when we talk about thermoregulation. And the next thing is newborn reflexes. They're the hallmark of their maturity. So based on their reflexes, and we'll go over this when we go over Ballard scores, we'll talk about how by just looking at their reflexes, we can tell their gestational age. If they were early or on time or even post dates, we can understand by the types of reflexes that are being exhibited how mature they are. As far as their assessment of behavior, the behavior of all human newborns, or neonates, I should say, is predictable at birth with 3 phases. There's 2 periods of reactivity, and that is separated by 1 period of a deep restorative and stabilizing sleep. When we look at the newborn immediately after birth, we are looking at their color, their tone, their respirations, their heart rate. We do a general survey of any major anomalies that we can see, and we get a general sense of the presence in the body. This is just a visual for those who need it. Don't worry about memorizing anything on this slide. This is just for those that like a visual representation. This is just all the different things we are assessing when a newborn is born. And so you can see that there's a lot going on. We need to assess APGAR scores, which we'll go over, their general characteristics as far as their length, their weight, their head circumference. We're looking at their umbilical cord to make sure there's 2 arteries and a vein. We're assessing their cry. We're assessing their temperature. We're looking at their skin color. So all these things are going on at the time when they're first born. Again, don't memorize this sheet. It's just something to kind of give you a visual representation. There are changes in blood circulation after birth. There are 3 fetal circulatory shunts that partially bypass the fetal liver and lungs, meaning that when babies are in utero, they do not really need their liver nor their lungs at the time. Mom's oxygenation and her respirations are oxygenating the baby through the placenta and through the umbilical cord, and their waste products of the infant or the fetus are being transferred to mom to get rid of. So they're not using their liver or their lungs, so these shunts help bypass that. And these 3 shunts are called ductus venosus, Fremont Valley, and ductus arteriosus. And again, we'll talk about these more closely in a couple slides here. These structures will close functionally after birth, meaning they no longer are needed once the baby's born, so they don't functionally work. However, they don't permanently close till several weeks, sometimes months after birth, but they will eventually close and just become ligaments. There are 2 umbilical arteries. Those carry deoxygenated blood and waste products from baby through the placenta to transfer into mom's blood for mom to get rid of those wastes. And then there's 1 umbilical vein which carries oxygenated and nutrient-rich blood to the fetus, again, via the placenta through the umbilical cord to the baby. We also assess something called APGAR score. This is an acronym for appearance, pulse, which is the heart rate, the grimace, which is our reflex irritability, activity or their muscle tone, and respirations, which is their respiratory rate. Every baby will get assigned an APGAR score at birth. Each is assigned a point ranging from 0 to 2. We obtain these APGAR scores at 1 minute of life and again at 5 minutes of life. And that's usually all that's required. Unless that second score is still less than 7, then we need to get an additional score at 10 minutes. There's a maximum 10-point scale. There's 5 items that we just talked about: the appearance, the grimace, the reflex irritability, etc. Each point can either get assigned a 0, a 1, or a 2. And there is a high correlation with a low 5-minute APGAR score and morbidity and mortality, meaning that at 5 minutes, the baby really should now be transitioning properly from the intrauterine life to the extrauterine life as far as breathing, color, heart rate, everything. That's why if they're still not doing well at 5-minute score, we'll have to do that additional 10-minute score. But there's a high correlation that if they're still struggling to breathe or adapt at 5 minutes, they may have some other issues going on as far as morbidity and mortality. The APGAR score is used to evaluate their brain function at birth, their circulatory status at birth, the effectiveness of their respiratory and circulatory adaptations now that they're not relying on mom anymore, and which babies need active assistance or resuscitation. So this would give us an idea: does this baby require supplemental oxygen? Does this baby require chest compressions? We would know by these APGAR scores who requires resuscitation. This is an example of an APGAR scoring sheet. So we look at heart rate, respiratory effort, muscle tone, reflex irritability, and skin color. So we talked about these are the 5 things that we look at. And you give these scores a 0, a 1, or 2. So if you look at heart rate, you see that if they had an absent heart rate, they would get a 0. If their heart rate right at that first minute of birth was less than 100 beats a minute, they would get a 1. And if it was over 100 beats a minute, they would get a 2. And so on and so forth. So you do the respiratory effort. You're looking to see if they have any, if it's weak or if it's strong. You're looking at their muscle tone, whether they're flaccid, if there's some flexion or they're well flexed. You're looking at reflex irritability, meaning any facial grimacing. If there's none, they get a 0. If there's some, they get a 1. And if they're coughing or sneezing or moving their faces, they get a 2. And skin color, they're either blue, pale completely, they get a 0. They get a 1 for extremities just being blue, and they get a 2 for being overall pink. I will tell you, when you're looking at skin color, 99% of the time, babies will only get a 1 for skin color. It takes a while for the circulation to completely go through the whole baby's body. And so those hands and feet stay blue a little longer because it takes a little longer for that well-oxygenated blood to reach those extremities. So it is not uncommon. In fact, it is almost always common that babies will have blue hands and feet for sure the first minute, oftentimes the 5-minute APGAR score, and even beyond. It can even be an hour or 2 after birth before those extremities start to really look pink. So not uncommon, and it's not bad if they get a 1 for color. The higher the score, the better the condition, but a 10 is not usually given specifically because of the extremities and the color. So if the APGAR score is an 8, so let's say we've done this scoring thing and we get an 8 at 5 minutes. What do we do? Well, at this point, that's a normal score. So between 8 to 10, we just support normal respiratory efforts. We maintain thermoregulation. We allow the baby to lay on mom's skin. We would continue with normal assessments. So the baby's doing well and adjusting well. However, if our second APGAR score was between a 4 and a 7, we know that they're having some moderate difficulty, and they may require some assistance. And then if they're between a 0 and 3, they have severe difficulty. They have distress in their adjustment. And when we're looking at low APGAR scores, we have to keep in the back of our minds what might be contributing to this. Is there an infection? Are there congenital anomalies that we don't know about? Is there physiological immaturity? Meaning, is this baby preterm? And maybe this is affecting how they're responding or adjusting. Were there any maternal medications taken by mom during her labor and delivery or before that might be attributing to this? And this is all something that we can look at that can influence this score. When a baby is first born, we want to promote what we call kangaroo care. And this is taking the naked, healthy newborn and placing them directly on mom's skin. And then both are covered with a blanket. So what do we know about kangaroo care, or what we call skin to skin? Well, we know that the evidence has showed that it could replace routine electronic warmers and L&D units, because once putting baby skin to mom's skin, or even dad or anyone else for that matter, it helps stabilize the infant's vital signs, especially initially. It helps stabilize their temperature. It keeps them warmer faster than any electronic warmer could. It helps initiate breastfeeding if mom is choosing to do that. And it does calm and comfort the infant. So we use skin to skin in a variety of settings. Specifically, after they're born, We use them if we want to help mom if she's having difficulty with breastfeeding. The first thing we suggest is skin to skin. We use it in the NICU to help stabilize their vital signs and to help them with their temperature control. We also use it just for comfort. So there's often procedures we have to do to newborns like newborn vaccines or blood draws. We will often place the baby on mom because it causes them their pain reaction to go lower, and then they're able to be comforted while they're getting a painful procedure. The other thing we do is we do newborn identification. So there's an identiband that corresponds to mom's number, and this is a number we put on usually their wrist and ankle. And this is where there's other identifying demographics on this information as well. It'll have mom's name, it'll have doctor's name, date and time of birth, boy or girl, and then the number that corresponds with the mom. So there's 2 ID bands that are placed on the baby, and then mom will get a 3rd band, and then oftentimes the hospitals will give a 4th band, either to the husband, the dad, the father of the baby, maybe even a relative of mom if there isn't a father involved. And this is a security reason. So in the hospital setting, if we are bringing a baby from the nursery to mom, we have to have her read off that identifying band, and it has to match the baby's band. So we know that she's getting the correct baby. Same thing if she goes to get her baby from the nursery. And this is important to understand that they must have the band on, meaning that if grandma is visiting and mom happens to be in the shower and we're bringing the baby to the room and grandma says, oh, you can leave the baby here, mom will be out in a minute, we can't do that. It has to be someone who's wearing a band that has to read the number, so we know we're giving the baby to the appropriate people who can get the babies out of the nursery. And also we want to make sure we have the right baby. So even if you know this is your baby, that you've gone from mom's room to the nursery and then back to mom's room again, we always double check by doing that ID band. There's another security measure called a HUGS tag. This is a security device that's usually attached to either the umbilical cord clamp or the ankle. And this allows us to secure the perimeter of the hospital unit. So usually there is some sort of sensor set up by stairwells, by exit doors, by elevators that will alarm if the baby who's wearing this HUGS tag gets too close to those perimeters. And the reason why is obviously infant abduction. We want to prevent that. So this is another security measure that I would say most labor and delivery units do. And then the other security feature that not all hospitals do, but some do, are footprints. So footprints are obtained initially at birth, and they're like fingerprints. We do a footprint of the baby just to have an identifying marker for that baby. So now we need to understand the physiological and transition from fetus to newborn. So we're going to look at what goes on when the babies are first born physiologically. So we talked about the birth to 28th day that we're calling the neonatal period, and this is neonate versus newborn. So there's a technicality in that. A lot of those words are interchangeable, but really neonate specifically is birth to 28 days, and then beyond that is newborn. This is a time of transition to their extrauterine life, so outside the uterus. And we talked about there's 2 periods of reactivity and 1 period of restorative deep sleep. So we're going to go into those. The first period of reactivity is where they are alert and moving. This is the optimal time for their interaction. So this is when they're first born, we tell moms they're alert, dim the lights, position them on face. That means mom's face to baby's face. We reassure them to do skin-to-skin contact. This is oftentimes the best time to initiate breastfeeding. This is that initial latch and suckle. They're the most alert. They're able to breastfeed quite well in this early first period of reactivity. The healthy neonates are usually born quiet and alert. So yes, they'll cry initially from all the stimulation of drying them off and assessment, but once all that's done, they're usually quiet and alert. So this is that first period of reactivity. The next thing is they have the sleep, which is this predictable part of that first period of reactivity or responsiveness, and we call that quiet time. So this again is, if you're a postpartum nurse or a labor and delivery nurse, this is where you would be initiating breastfeeding if that's mom's choice, because this is a really ideal time to start that. So from birth to 2 hours, the heart rate will increase initially, and then it will stabilize between 120 and 130 beats per minute. So it's still rather quick when we talk about this versus in adults, but this is not uncommon. The respirations are usually irregular. They are often tachypnic and a little bit shallow. Those will again stabilize between 30 and 60 breaths a minute. When we auscultate the lungs of the baby, we might hear some fine crackling. We might see some nasal flaring or grunting or some shallow retractions of the chest, but this should resolve in about an hour. We call that transitioning. So we give the babies about an hour to transition from intrauterine to extrauterine breathing. So some of these findings you find are normal within that first hour. They really should resolve after this time. The baby may startle, that's one of their reflexes. They may cry, they may move their head from side to side. These are all things that they initially can do. You can hear bowel sounds, usually within the first hour of life, and they can actually have their first bowel movement, which is called meconium, within that first period of reactivity. And again, good time to initiate breastfeeding. Then they go into what we call a deep restorative sleep. This usually lasts 60 to 100 minutes. There's sleep or at least decreased activity. They're not easily awakened and they have really no interest in breastfeeding. So I always say they're up and alert for the little bit of those 2 hours, and then they're exhausted just from the whole birth process itself. And they go into a really deep restorative sleep. This is not the ideal time to try to get them to open their eyes or to breastfeed. They really require the sleep to, basically what it says, to restore. Then there's a second period of reactivity, and this occurs after that restorative sleep. And this is a great teaching time for moms about their newborn babies. Newborns will have special skills. They'll have what's called orientation. And this is the familiarity or the preference for human face or staring at objects. So you might see eye contact between the baby and the mom. They prefer facial symmetry, and so they're looking at mom's face. Habituation is their ability to respond to visual or auditory stimuli. So they'll startle if a loud noise happens or something that goes in front of their face, it'll cause them to startle. They have motor maturity, meaning that they're able to bring their hand to their mouth. They have self-quieting, which they can change from a quiet to a cry easily, and then you can rock and hold them or pat them, and they can go right back down to the quiet stage. So they can try to transition from state to state fairly easily. And they have some social behaviors they're born with. They can cuddle in, they can quiet when being held, swaddled, rocked. The second period of reactivity is 4 to 8 hours. And this is a brief period, again, where the heart rate is now tachycardic, the breathing is tachypnic, skin color changes may happen, mucus production changes. So that first period of reactivity, their vital signs are a little bit increased, their heart rate and their respirations, their activity. Then everything kind of slows down and stabilizes during that restorative sleep. And then during that second period of reactivity, it kind of briefly jumps back up again. So you might see the heart rate go back up again. You might see the respiratory rate go back up again. That's normal during the second period of reactivity. And then it will stabilize after that. So in utero, lungs are similar to what we call like a wet plastic bag that are stuck together with minimal blood flow. They've not been using their lungs in utero, so they've been just kind of like stuck together. Within the first few breaths, the lungs and the alveoli expand and blood flow for gas exchange begins. So this is where those circulatory changes occur that allow blood flow now to change from a fetal blood circulatory system to now a neonatal blood circulatory system. So when you look at that picture down below, those are collapsed alveoli, again, that are stuck together, that aren't open or expanded. That's initially what they look like in utero. And then as the first breath occurs and the lungs and the alveoli expand, they open up to that normal alveoli picture. And this is what is allowing gas exchange outside of the uterus. So the umbilical cord. This is what connects the baby in utero to the placenta. So we talked about this earlier. There are two arteries there should be two arteries in that umbilical cord, which carry blood and waste products like CO2 from baby's metabolism back to mom, and then she gets rid of that. This is where we bypass the liver. Then there's one vein that carries oxygenated blood to the baby from mom. And this will constrict after the cord is clamped. So that's a picture of the cord being clamped over there. And it will become a ligament, and this can take several months. Some babies don't initially cry until that cord is clamped. And you notice that over those veins and arteries in the umbilical cord, that's called Wharton's jelly. This is a protective coating to help protect those, delicate arteries and vein that are inside that umbilical cord. So when I said they usually have two arteries in one vein, there are some babies that are born with what we call two vessel cord, one artery and one vein. And sometimes that is something more serious conditions, and sometimes it's benign, and we're not exactly sure why some babies only have one. But most babies should have what we call a three vessel cord which consists of 2 arteries and 1 vein. So we talked about the shunts earlier that they have. The first one is called a foramen ovale. And in normal cardiac structure in newborns, there's a small hole, or what I like to think of like a door, between the right and the left atria. And these are those 2 upper chambers of the heart that are located in the septum wall. This is what's directing oxygenated and nutrient-rich blood from the placenta to the developing brain by bypassing the fetal lungs. So we're getting that direct oxygen and nutrient-rich blood that's coming from mom through the placenta right to the baby's fetal brain, and we don't even use the baby's lungs. We bypass it. That foramen ovale shunts the blood toward the brain and away from the lungs at that time. So normally this will close as blood pressure rises in the left side of the heart after birth. So there's a difference in pressure between the right and the left sides of the heart, which allows the blood to flow through. This will close functionally with the onset of respirations. And again, permanent closure may take several months. So you see the picture to the right where the blood, there's that little shunt door. This is what's allowing that blood to move depending on the pressure of the heart. So this is what's allowing it to bypass those lungs and go right to the fetal brain. And once the baby's born and takes that breath, that door or hole, if you will close, and the circulatory system will go through the lungs like it does for everyone else, except for the neonate. So the next shunt is called the ductus arteriosus, and this is where blood vessels connecting the pulmonary artery to the aorta. This allows most of the blood from the right ventricle to again bypass the fetal lungs, so both of these ducts are bypassing the fetal lungs. Dilatation is maintained by placental prostaglandins and low oxygen in the blood. So that's what's causing this shunt to stay open or to dilate, is because of these prostaglandins that are found in the placenta and the low O2 count in that blood. And this constricts with the onset of respirations. And this becomes a ligament after a few months. So the same thing. So it's a similar process where this is bypassing the lungs. The ductus venosus is the last shunt we're going to talk about, and this connects the umbilical vein to the inferior vena cava and shunts or redirects a portion of the left umbilical vein blood flow directly to the inferior vena cava. This is what allows oxygenated blood from the placenta to bypass the fetal liver, because we don't need that anymore, and bring it right to mom to get rid of those waste products. So remember, we're bypassing liver and lungs in the fetus because they are not needed. Mom is doing all that work for us. So these shunts allow all that to bypass or redirect that blood flow. This is a picture for those who are visual learners. Again, you do not need to memorize it, but it's showing you where that open foramen ovale is. It's showing you where that ductus arteriosus is and what it looks like once it's closed. It's also showing you how it's shunting blood flow away from the liver and the lungs. And it's showing you how that blood is carried from the placenta through the umbilical cord, those 2 arteries and vein, to the fetus, and then how it goes back again to the placenta for mom to get rid of waste. So again, do not need to memorize this picture, but for those who are a visual learner, this is a good representation. Now this is a video, I'm not going to play it right now, but when you go back to your PowerPoints, you can take a look at it. It's just a fun little song that was created on YouTube that students like to watch. It also kind of describes what these things do in a more fun way. So when you get a chance, go ahead and play that video if you'd like, and it's another way to kind of see the process of how this happens. The next thing we're going to talk about is the circulatory changes. There's peripheral circulation, which is established slowly over the first 24 hours. So this is what we were talking about when we said those APGAR scores, when you only get a 1 for color. This is called acrocyanosis, which means that there's blue extremities, blue hands and feet. So it is very common to have acrocyanosis within those first 24 hours because that peripheral circulation is taking that long to establish. We already talked about the red blood cell count is initially high for newborns. This is often why newborns have that ruddy or that red appearance, because all those red blood cells are coming to the surface of their already thin skin. This will fall over the first week. The count won't be as high as it is initially. Those will eventually fall. And the breakdown of red blood cells is what's related to neonatal jaundice. Red blood cells, once they break down, the byproduct of them is bilirubin. And when you have hyperbilirubemia or hyperbilirubin in the system, this is what causes jaundice. So because their red blood cells are initially high, because they're short-lived and they break down frequently, and they're starting to fall during that first week, this is what's causing that breakdown and what's causing issues with newborn jaundice, which we'll go into in a moment. So when babies are first born vaginally, they experience something called the thoracic squeeze. And the thoracic squeeze is when the vaginal birth process pushes excess fluid out of their lungs. So when they are born by cesarean section, they're often at risk for what we call transient tachypnea of the newborn, or TTN, which just means they're tachypnic initially because they didn't get the benefit of that thoracic squeeze. When you're born by C-section, you're just lifted from the uterus out. You don't pass through that birth canal, so you don't get the benefit of pushing those excess fluids out. When you have excess fluids in the lungs, you may experience some tachypnea as the baby is trying to work those extra fluids out and breathe productively. The next thing we see is that surfactant is present in the full-term infant, and this allows the lungs and the alveoli to expand with those first few breaths. So it's surfactant that is established in utero that allows the alveoli to not be sticky anymore. So remember we said they're like wet bags and sticky to each other? The more surfactant they have, the more full term they are, it allows those alveoli to open and take in that gas exchange. And it prevents alveolar collapse or respiratory distress syndrome. So without that surfactant, or with little surfactant, those alveoli cannot expand fully, and without that, they cannot do effective gas exchange. This surfactant is produced in utero, and it starts about 25 weeks, and it's not complete or at adequate levels until the fetus is at least 35 weeks. So it takes about that long for them to establish proper surfactant levels to allow those alveoli to function adequately. This is something we see when we talk about late preterm infants. Those are infants that are born not quite preterm, not quite term. They're kind of in that weird gray area where they often have problems with TTN, or the transient tachypnea of the newborn, because of the inadequate levels of surfactant. We'll talk about that later when we talk about the respiratory system of infants. The surfactant, again, the outer walls of the alveoli of the healthy lung are lined with this protein called surfactant. It will help reduce the surface tension of fluid in the lungs and help make the small air sacs of the lungs, or those alveoli, more stable. It keeps these sacs inflated when you inhale and keeps them from collapsing when you exhale. So that's what surfactant does. In other words, it maintains alveolar stability needed for gas exchange. So babies with too little surfactant, those who are sick or preterm, remember before that 35 weeks where there's not adequate production made, it takes much more effort for them to breathe, and they become exhausted much more quickly. Then we're going to talk about thermoregulation, and when we talk about that, we talk about brown fat. So brown fat is a very special tissue that allows heat production in the newborn because they have the absence of the shiver mechanism. And we want to prevent rapid heat loss in cool environments. And there's 4 ways to do this. We talk about how heat is lost in the newborn, and those are by ways of conduction, convection, radiation, and evaporation. We're going to talk about those in the next few slides. Brown fat helps maintain their temperature. When you think about brown fat, you don't obviously see it, it's in the newborn, but we think about it as it covers them almost like a vest. So if the newborn was wearing a vest, wherever the vest was on their body, that's where the brown fat is located. So it's across their back and down the front in those areas from the, below the neck to the abdomen. That's really where those high concentrations of brown fat are, and that's what helps them thermoregulate. It was originally thought that once the newborn became older, that brown fat disappeared after infancy. But now we're finding that, no, there are small amounts of brown fat still in adolescents and some adults. So we still have a little bit of it as we get older, but we don't have obviously as much as a newborn, and we don't use it for thermoregulation as the newborn does. So we talked about how heat can be lost by the newborn, and quite easily heat can be lost by the newborn for several factors. Their size, their thin skin, their absence of being able to shiver, their difficulty in thermoregulating. So these are the 4 ways that an infant can lose heat. So those 4 ways are convection, radiation, evaporation, and conduction. So convection heat loss is when the body goes to cooler air. So this would be an example of why we place a cap on the newborns or why we keep them away from drafts, because we don't want the body to be presented near cooler air. The next one is radiation. This is when the body to cooler air surfaces, but not in contact. So an example would be that we are near a cooler surface like an outside window. We're not in contact with the window and it's not a draft, but because it's cooler surfaces near them, they can lose heat that way as well. Then there's evaporation, which is liquid converts to vapor, heat is lost. So this is why when a newborn is born, when they're wet, because they were in amniotic fluid, we immediately dry them, because the longer they stay wet, the colder they'll get as that liquid starts to convert to vapor, and then their heat is lost that way. And lastly, we call that conduction. This is when the body is placed specifically on cooler surfaces, such as a crib or a scale, even the cold stethoscope that you're using to listen to their heart, anything that comes in contact with them that's cooler than their body temperature, this is another way for them to lose heat as well. So again, these heat loss mechanisms, for people who are visual learners, this is just kind of a picture for it. I know it's not a great picture, but we're looking at, for convection, that flow of heat from the body surface to the cooler air. So examples of preventing convection heat loss is to eliminate drafts, such as windows or air conditioning units, to reduce this transfer of heat. In conduction, we talk about it's the transfer of body heat to a cooler solid object in contact with the baby. So we want to make sure we cover surfaces with warmed blankets or towels to minimize conduction heat loss. So this is why we put like a baby blanket over the scale or over a crib so that they're not touching a cold surface. This is why nurses will often warm their stethoscope up in their hands before they touch the baby with the cold stethoscope. In radiation, we talk about the transfer of heat to a cooler object that's not in contact with the baby. So we want to make sure that we put them away from a cold window surface or an air conditioning unit, as they can lose just their heat by being near it, even if that current isn't going. And last is evaporation. This is that loss of heat through conversion of liquid to vapor. So again, that amniotic fluid that they're in, we need to dry them off immediately. So thermal regulation, that's a big thing that infants have to do during their initial time that they're born. So a newborn's baby's temperature may drop several degrees after delivery because the external environment that they are now in is much cooler than the intrauterine environment. So it was nice and warm and heat regulated in mom's womb. And now that they're out, the temperature is much cooler and they can drop several degrees because of this. This can cold stress a newborn. So cold stressing a newborn is when there's an increase in the metabolic rate of the infant, and it increases their oxygen demands and their caloric consumption, and this can lead to metabolic acidosis. So we're talking about an increased metabolic rate because they're trying to stay warm, so they're trying to generate heat, will increase the amount of oxygen that they demand. When they increase their oxygen demands, they also increase their glucose demands. They are burning glucose to try to generate energy. And this can lead to hypoglycemia, which can be very dangerous, if not life-threatening, to the newborn. And they're starting to use up all their glucose to try to stay warm. And this can lead to a metabolic acidosis. So this is how easily it is for newborn infants to get cold stressed. So it's important that we are following those measures of keeping them warm and eliminating or reducing the heat loss through those 4 methods that we just talked about. So again, a visual of how being cold can go through all this processing that we just talked about and then eventually lead to that metabolic acidosis state because they're trying to stay warm. So another way to think about it, again, increase the respiratory rate because they're cold. They're going to consume more oxygen. Their pulmonary and their peripheral vascularization will constrict. There's less oxygen uptake to the lungs effectively, so they need more oxygen. So there's less oxygen that's getting into the tissues. This decreases their PO2 and their pH, which leads to this metabolic acidosis. Also, hypoglycemia is a result as they use up their glucose stores to stay warm. And so usually a normal glucose level for an infant is for a newborn or a neonate is between 40 and 45. So anything less than 40 often results in a protocol on what we need to do to help that baby get that glucose back. And remember that glucose is imperative for the newborn brain. So everyone actually needs glucose for their brain. So if the baby is using up their glucose stores to stay warm, they can actually eventually lead to brain damage or death as they don't have enough glucose to support that brain function. So when we're looking at the newborn, we're looking at their vitals. Obviously, initially we're taking vitals quite often, initially, and then very often the first few hours, then the first few days of life, and we're watching, again, they're transitioning. So the apical pulse for the 1 minute that we listen to should be between about 120 and 160 beats per minute. Their respirations, when you obviously listen by stethoscope on the right side of the chest for, again, a full minute, you should be listening to all these vital signs for at least a full minute, should be between 30 and 60 breaths per minute. Initially, we listen for these vital signs at least every 15 minutes for 4 times, and then we go to every 30 minutes times 2, and then every between 4 to 8 hours. And this is also generated by the protocols of every hospital that you're in, so it might be slightly different where you do your clinicals or where you do your work at based on their protocol. We also do an axillary temperature, and this should be between 36.5 degrees Celsius and 37.5 degrees Celsius. Again, might be slightly different in different organizations or units that you're working in, but in general, these are typically the vital signs that you're looking for. And if you're being tested on them from me, these are the ones I want you to look at. The 120 to 160 for heart rate, the 30 to 60 breaths per minute for the respiratory rate, and the temperature to maintain between 36.5 and 37.5. Keep in mind that low end of that temperature, you really don't want to see it go lower than that, because that's when that whole cold stress begins. When it falls below that 36.5 is when they're going to be using up that glucose and taking up that oxygen, and they're really going to lead into like a hypoglycemic state or a metabolic acidosis trying to stay warm. Excuse me. So immediately after birth, we give them erythromycin ophthalmic ointment, and this is given right into the eyes right after birth, and this is to prevent gonorrhea or chlamydia-related ophthalmia neonatorum, which can lead to blindness. So we do this generally for every patient. Now, a patient can refuse it if they don't want this baby to have it. It's like an antibiotic cream. We do it because oftentimes people do not know that they have gonorrhea or chlamydia if they're asymptomatic. And so it's kind of a preventative measure that we tell everyone just in case, because if they do have it and it's untreated, your baby could go blind. So this is just kind of a easy preventative antibiotic measure that we can do to prevent that, and specifically in cases where you don't know you had it. The other thing we do right at birth is we administer vitamin K, which is a fat-soluble vitamin to promote clotting and prevent vitamin K deficiency of the newborn. So babies have immature clotting factors. They can bleed out easily. So we give this vitamin K to help stimulate that clotting production. We give it in the thigh. We do it at a 90-degree angle right into the vastus lataris muscle, and it's usually given between the first 2 hours of birth, oftentimes right in the delivery room. Right after birth, we assign the APGARs, we do the vital signs, we keep them warm, we dry them off, we give them the erythromycin in their eyes, we give them the vitamin K shot in their thigh. That's kind of almost everything that we do initially once the baby's first born. So now we're going to look at the newborn physical assessments. So again, when you're in clinical, or obviously if you're working the postpartum unit or in the nursery, this is how we're physically assessing our newborn. So we look at newborn skin, which will vary depending on the length of pregnancy. Premature infants will tend to have thin, transparent skin, and the skin of the full-term infant tends to be thicker. By the baby's second or third day, the skin will lighten somewhat and may become dry and flaky. Remember, we said initially it might look more red because of those increased red blood cells specifically coming to the surface of the skin. And now it's starting to become dry or flaky because they were in water for so long and the amniotic fluid, and now it sometimes looks a little flaky. It's not uncommon for the skin to turn red when the infant cries. And again, lips, hands, and feet that may turn bluish or spotted is called mottled, and this often occurs when the baby is cold. Do not confuse this with acrocyanosis. So hands and feet that are blue initially, remember those first 24 hours, is acrocyanosis, is not uncommon. It's never okay for lips or central face or chest to be blue. That is always cyanotic. And when it is spotted or bluish and mottled, that is telling you that the baby is cold. So that's a little bit of a different variance than acrocyanosis. A healthy newborn at birth will typically have deep red or purple skin, Bluish hands and feet, again, the acrocyanosis. The skin will darken before the infant takes their first breath and when they make that first vigorous cry. So they often come out looking kind of purple, and that usually stuns a lot of parents when they first see. They think, is the baby okay? That's normal. So you notice this baby's picture up in the right. They're covered in this thick, waxy, cheesy coating. We call that vernix. It's a covering that protects the skin from being in amniotic fluid. So it protects that skin. The vernix should be washed off during the first baby's bath because that vernix can trap in that wetness and keep them cold. The longer they're in utero, the more term they are, the less vernix they'll have. So that's starting to wash away or wear away as they get closer to term. So a preterm infant will be really, really covered in this. As an infant who is term or even post-term or post their due date will often have less vernix, if not just very little, because it's already starting to wash off. They are born with something called lanugo. Lanugo is that fine, soft hair that cover the scalp, the forehead, cheeks, shoulders, and back. It's more common when the infant is born, again, a little earlier before their due date, and this hair should disappear within the first few weeks of life. So it's just the soft coating you can see in the picture of hair. That's called lanugo. This is what acrocyanosis looks like. So it's that centrally pink. So notice their face and their chest are pink. It's just their extremities that are blue. So if you look at those two babies holding hands, their hands are a little bluish. That is acrocyanosis, completely common for the first few hours. Different skin conditions or spots that we may notice in the baby. One of these, this is called, the old term is called Mongolian spots. They now have renamed it. They're called cerulean spots. These are flat, gray to blue. They almost look like bruises. More common in dark-skinned babies. They emerge on the skin, usually near the buttocks or the back, and they will fade within about a year. So those are called cerulean spots, and that's what they look like. It is important that when you're assessing that initially, that you mark that on their record. And I'll tell you that as children get older, into like a year old or maybe slightly older than that, they can still maintain these on there, and they do look like bruises. So there have been times where an ER nurse or doctor has mistaken that for maybe bruising or physical abuse, and it's important that it's noted somewhere in their record that they were born with this cerulean spot so they can differentiate between that and a bruise. The next thing babies can be born with is something called milia. These are white pimples or papules, normally across the bridge of the nose and the face, right underneath that epidermis. And again, they will disappear on their own. We tell parents, don't try to wash them off, don't try to pop them. It's just these little immersion papules that occur underneath the epidermis that will disappear. And this is very, very common. I would say most babies have some form of this. Another thing that babies can be born with is something called erythema toxicum neonatorum, or what you'll hear called in the hospital setting a newborn rash. So these are white papules with a red base, or what we will often refer to as newborn rash or newborn acne, because it appears like it's acne. Again, it can be sporadic, just a few spots here or there on the body. Babies can be covered in it. There's nothing you do about it. You don't want to, again, scrub them off or pop them. They will go away on their own. So it's completely common, completely benign. Some other things that they may be born with, one is called a telangiectatic nevi, which is a flat pink or red surface with irregular borders. It's a collection of blood vessels, and you can see on that baby's picture on the top, it's right between the eyes, right on the forehead. That's a very common spot. These will often be called, in layman's terms, an angel kiss or a stork bite. You'll hear nurses or doctors refer to it that way. It's usually somewhere in that area. Forehead, between the eyes, on the head, somewhere near the face. These are benign. They will go away on their own. Usually takes a few weeks to a few months. Another condition is called a nevus flammeus, which is a discoloration of the skin due to a vascular anomaly. This is one of the skin conditions that can be or will be permanent. It does not disappear as time goes on. This is referred to in layman terms as a port wine stain. So you can see this baby has that staining across their face. Now, how do you tell the difference between that and something like maybe an angel kiss or a stork bite? This will not blanch. So if you push on the baby's stork bite, it will blanch and then the redness will come back and appear. In this port wine stain, that will not happen. This will not blanch. This will get bigger. This area of port wine stain will get bigger as the baby gets bigger, eventually until they're in almost sometimes into an adult state. So these are when you see adults with that discoloration on the forehead or the face. This is that port wine stain that is permanent. So it's not dangerous to the baby, but it's definitely something you have to deal with your new parents as far as like accepting it and understanding that their baby will have this anomaly, if you will, for the rest of their life. Another mark is called a nevus vasculosus, which is a small but very closely packed blood vessels. This is layman terms called a strawberry hemangioma or a strawberry birthmark. This is a little bit different than the angel kiss or the stork bite because it is raised. So it initially starts off flat and it's a much darker color than the stork bite. The stork bite looks kind of pinkish where this looks really, really dark red. And it is a closely packed red blood cells which gives it that color. As the baby gets older, the vessel fills more with blood. So it can get bigger, and it usually can get bigger for the first year or so of life. Once about a year, it stops growing, and then it can take up to a year to a few years to completely dissipate back into the system. So this is something that can be found anywhere in the body, but usually upper torso up. So usually like the arms, the face, the head, these are common spots for these strawberry birthmarks. And again, they will continue to grow for about the first year of life, and then they will start to go away on their own after that time. So they're not permanent, they just take a while to go away. They're often not treated with any kind of surgery or laser treatment because when you do that, there's a risk for bleeding because of how closely packed the red blood vessels are, and because it can cause scarring. However, they will remove them if these nevus vasculosus marks occur anywhere that can impede on breathing or eating or vision. So oftentimes these vessels can come like on an eyelid, which is compressing the optic nerve. It can be by the nose, so it can impede breathing. It can be in the ears, so it can affect hearing. So if they're in a spot where they're affecting any of those things, they will try to remove them surgically or by laser. But if they're in a benign spot like a forehead, an arm, the back of the head, and they're not affecting anything, they'll just let them go away on their own. Another skin condition is called petechiae. These are little pinpoint spots that are little broken blood vessels. This often occurs when there's been a lot of pressure during the birth, through the birth canal. So you will see these when little red blood cells have ruptured. You also see these on moms sometimes after they've been pushing. They can get petechiae in their cheeks and their face from just holding their breath in and pushing with a lot of pressure. You can have these little petechiae that come out. Another condition is called polycythemia or plethora. This is that red, ruddy color I was telling you about. So this can occur again initially because of the increased amount of those red blood cells, that high count, and because the skin is so thin and they come to the surface, this is that ruddy color they can become if they cry. So this is not unusual. There's another condition called a Harlequin sign, which is a unilateral erythema. So there's like a disruption in the way the circulation is carrying over from one side to the next. This again is benign. It is not that common, and it will eventually even out throughout the skin. It's just when the body's trying to regulate that blood flow. And then lastly is trauma. You can get marks from a vacuum extraction when you're delivering, a forceps that was placed, or even sometimes a laceration if the head was accidentally sliced during like an episiotomy or a cut in a C-section. So sometimes we can see trauma that was man-made from delivery. So when we're talking about the newborn head, we're talking about the different shapes it can be in. So first we'll talk about molding. Molding is that elongated shape of the fetal head that molds that way to accommodate the passage through that pelvic architecture. So what we would refer to as a cone head. So that's when that baby initially comes out and has to kind of squeeze their head, kind of elongate it in order to fit through the pelvic bones. Another condition, and that's common, that'll go away. Almost every baby who's born vaginally will have some form of molding, some more significant than others, and that will reshape and back to the normal looking size head within like a day or so. Another condition that can occur is called caput suicidum, which we just refer to as caput. And this is where serous fluid collects, and it's across those suture lines as a result of pressure during labor or localized edema. So just when babies, just from the pressure of labor itself and birth, it kind of pushes that serous fluid collection. This will cross those suture lines and it'll look more centrally placed. A cephalohematoma is a collection of blood as opposed to fluid, and it does not cross suture lines. So this is caused by a disruption of the vessels during the birth birth process, oftentimes from like a forceps or a vacuum, but can just occur from natural childbirth as well. And this will occur on one side of the head or the other, but does not occur centrally because it won't cross those suture lines. So this is when we're talking about the head, this is what we're looking at as far as the fetal head molding. So we're talking about that caput, that cephalohematoma. So if you look at that picture to the right, that's just that head molding. And then you can see on the top of the head where it's starting to kind of like puff up. That's where that caput might occur, where that serous fluid might collect. And there's another condition which is a little more rare, but more serious, called a subgaleal hemorrhage. And we'll talk about that here in a moment. So again, caput is localized edema. It crosses suture lines, so that's a big difference between that and cephalohematoma. And it's from pressure on the head during labor and birth. It feels soft and mushy, so it'll feel kind of like a water blister because it is an area collected with fluid. As opposed to a cephalohematoma, which is a collection of blood associated with procedures like forceps, it's firmer, it has clearer marked edges, it's warmer to the touch because it's filled with blood. And it again does not cross suture lines, so it'll be on one side of the head or the other versus centrally. So this is a picture. On the left is a picture of caput, and on the right is a picture of a cephalohematoma. So they're similar, but notice that the caput is more centrally, like at the end of the cone of that head. And again, if you were to feel it, it would feel room temperature, it would feel mushy, it would feel soft. That cephalohematoma, you can kind of see in the hairline that it's more delineated with a firmer edge. When you felt it, it would not mush. It would feel firmer. It would feel warmer. And if that baby's head was turned slightly, you would notice it was just specifically on that right side of the head and not anywhere centrally. The subgaleal hemorrhage that I mentioned is a serious finding, but fortunately not that common. So it's a rare, potentially lethal condition caused by the rupture of these emissary vessels between the dural sinuses and the scalp veins. This is important for us to have accurate head circumferences during this time because a subgaleal hemorrhage, I don't know if you can see here, but if they have these ruptures, notice how the blood is starting to collect back here into the neck, back here. So this is internal hemorrhaging that is occurring that can eventually kill the baby if not recognized. So it's important that if you have a baby that has a subgaleal hemorrhage, that we're constantly monitoring head circumference, because as they're starting to hemorrhage, that area will get bigger and bigger, specifically around here where the ears are and back by the neck, because where that blood is flowing. So you want to make sure that you're having an accurate measurement of how much blood is actually being internally hemorrhaging. So this is important to take note of. When we talk about the Ballard score, this is what we're talking about, how we assess a baby's gestational maturity. So we talked way earlier at the beginning of the slides about reflexes that are born, and it's the hallmark of how mature they are. This is what we're talking about. This is called a Ballard scale. And the assessment is usually done during the first bath or the first admission to nursery. And it's a gestational age assessment tool that evaluates both physical maturity as well as neuromuscular maturity. So this is a picture of the Ballard score. This will be part of one of your clinical assignments during clinical that you will have to do. So these are pictures of how we do this Ballard score. So if you see, the top is the neuromuscular maturity, and this is assessing the posture of the baby and different ways that the baby's reflexes work. So we're looking at, like, the square window is assessing their wrist angle. The arm recoil is bringing their arms down and having them recoil back to a flexed position. The popliteal angle has to do with putting the knee to the abdomen. The scarf sign is bringing the arm of the baby across their chest and looking about how far they can bring that arm across. And the heel to ear is just that, bringing the heel of the foot to the ear and seeing how far you can stretch that. And then the physical maturity, we're looking at the amount, the skin, the texture, and the color. We're looking at the lanugo, the amount of that. We're looking at the creases in the plantar surface and the amount that they have. We're looking at the breasts to see if they are formed, if there's a breast bud felt, how big that areola or breast bud is. We're looking at the eyes and the ears to see that the eyes are either fused or all the way open, and the ear formation as far as the pinea goes starts off soft or not fully formed and kind of flat to a well-curved, thick cartilage in the ear. And then we look at genitalia. For the boys, we're looking at the scrotum, the amount of rugae or wrinkling on the scrotum, and if their testes are there and descended into the scrotum. And for the girl babies, we're looking at whether or not their clitoris is more prominent in the preterm infant, or if it's more pushed back, and the labia majora and minora are covering the clitoris with those skin folds. So if you look at the scale, you're looking at that on the left side of the scale. Those are the findings you're going to find with the more preterm infant. So you're looking at the 90-degree screw or over 90-degree screw window, the flexibility in how they move their arms and legs, the sticky, friable, transparent skin. They have no lanugo. They have almost no creases on their plantar surface. Their breast buds are imperceivable, meaning that you cannot feel them. Their eyes can possibly be fused or just slightly open. They can have very flat, soft pinna, and again, their testes wouldn't be descended in the boy. The scrotum would be flat without any wrinkling, and then the girl, the clitoris would be very, very prominent without any kind of covering from the labia majora and minora. And then as they get further on that right hand, those are your more term to post-term infants. That's the way that they would look. Notice their flexion becomes from more of a flaccid position to a more flexed frog-like position. Their square window becomes a 0-degree angle, but the rest of their movements of their arms and legs become more restricted, meaning that they're not as flexed or don't have the flexibility that the preterm infant does. And then again, the other findings you find in the physical maturity as far as the deep cracking of the vessels of the skin, the creases over the entire sole, the full areola with breast bud that's perceivable, the thick cartilage in the earlobe, or excuse me, the pinna. So we're looking at all that, and this is how we're measuring. We're having an idea of what the gestational age of the baby is. So when we look at the newborn, again, those first 24 hours after birth, we're looking at those 6 things. We're looking at neuromuscularity, posture, square window, arm recoil, popliteal angle, scarf side, and heel to ear. So this is an example of posture. So if you can see between the 3 babies, notice the first baby, who's obviously a small baby, preterm infant, notice how flaccid the legs are. So they're long, they're extended. The arms are up, but not tightly to the body. And as it progresses to that term baby on the right, this is a baby that is in that frog-like stance. The legs are flexed close up and with knees bent to the body, and the arms are closely flexed to the body. So that's the difference in posture as you get an older, more mature gestational age infant. The square window, that is pushing the wrist down and measuring that angle between the arm and those fingers, measuring the degree of the angle on that. And there's a video on this for you guys to watch as well. The arm recoil is just simply bringing the baby's arms down to the side of their body, letting go and seeing to which angle they bring them back up to. Popliteal angle is you're extending the knee of the newborn and measuring that angle of the calf to the thigh. You're measuring that inner angle. And again, depending on that angle tells you how mature that infant is. Scarf side is moving their arm or their elbow across the chest to see how far it reaches. Notice that in that first picture, that would be more of a preterm infant where it can go completely across because they have a much higher flexibility rate and not a lot of resistance. But the more term they get, it's harder to bring that elbow across. Sometimes it won't move at all from that fourth position. And so this is, again, a maturity scale for that. Heel to ear is bringing that heel to their ear. So this is obviously a preterm infant. You can bring that heel almost directly to their ear. As they get more term, you won't be able to do that. You won't be able to get that ear, that heel that close. And you can also see with their skin, see how shiny and taut and transparent it is. That's typical of a preterm infant's skin as opposed to a term infant. When we look at the physical maturity, we're looking at skin, lanugo, plantar surface, breasts, eyes, ears, genitalia. So skin, we're looking at the texture, the color, and whether or not we can see visible veins. The lanugo, we're looking at the amount. So keep in mind with a preterm infant, they are covered in a lot of hair. So you can see, I don't know if you can see closely, this baby has a ton of hair. So they'll have a lot at first, and then as time goes on, they'll start to lose that hair, and they'll have like balding spots by the time they're term. When I say they have no hair initially as like a very preterm infant, I'm talking about no hair anywhere, and that even includes eyebrows and eyelashes. So initially they have no hair at all. Then they have hair everywhere, and then that hair starts to fall off, and then by the time they're term, they have balding areas where they have hair patches, maybe on the back of their shoulders or on their back, but just kind of in patchy amounts. And keep in mind too, lanugo can also be ethnically related. So there are some ethnicities that their babies are just born a little more hairy than others. When we look at their plantar surface, we're looking at the term infant versus the preterm. Notice the creases in their feet. So they both have creases, but the term infant is more delineated, it's marked, they're deeper creases, as opposed to the preterm infant that just has these like light brushings of creases along there, but not very deep. Also notice the skin right there. Notice how much more shiny and red that preterm infant skin is compared to the term. When we look at the breast, we're looking at to see if the areolas are raised and stippled and if there's a breast bud present. So the more term they are, the more raised it will be and the bigger the breast bud will be. When we're looking at the ears, notice the term infant's cartilage versus the preterm. So the preterm infant, it's going to be soft. It's not going to recoil as quickly. It's not as delineated in its curvature, and it's a little flatter as compared to the term infant, where it's going to be more like the adult cartilage. So if you feel your pinea right now, it's hard cartilage. If you fold your ear over and let it go, it springs back. That's called ear recoil, and the faster it recoils, the more term the infant is because that cartilage is harder. When we're looking at genitalia, we're looking at, again, the female clitoris and the labia majora and minora. And in the boys, we're looking at the scrotum, the amount of rugae or wrinkling, and whether or not their testes are descended. So we're looking at those two things. This is the boy baby. We're looking at these little wrinkling of the scrotum. We're feeling to see if these testes are descended in the scrotum. In the girl baby, these are the coverings we're talking about, the labia majora. This is the clitoris that's very prominent initially. So oftentimes in a preterm infant, it's hard to sometimes determine or differentiate whether or not this is a girl or a boy, because sometimes this prominent clitoris could look like the beginning of a penis. So the more term they become, this clitoris retracts in, and these coverings or this labia cover over that, and so you don't see that initially. So you'll see that this picture more commonly in a preterm infant girl. The next thing we're going to talk about is group beta strep, which is also referred to as GBS or beta strep. They're all the same thing. So 50% of women have what's called a normal flora bacteria, and this is often occurring around the vagina and the rectum. It is not sexually transmitted. It is not symptomatic. It is not something they caught. It's just the normal flora bacteria that's on their body. And what happens is that this GBS status occurs in about 25% of our labor or our pregnant patients. So this means that 1 out of 100 to 200 babies that are born may develop signs of GBS. So when I say this is mom's normal flora bacteria, I'm saying that it's her normal flora bacteria, meaning that it's not baby's normal flora bacteria. So if the baby passes through the birth canal and mom happens to test positive for this group beta strep at this time, it can cause sepsis in the newborn. And GBS is the most common cause of sepsis and meningitis in the newborn. So when I say moms get tested, it's because this GBS status on moms, this normal flora bacteria, is transient. Sometimes she'll have it, sometimes she won't. And because it's asymptomatic, she will never know. So, and it's not causing any harm to her. So we have to test this toward the end of her pregnancy, usually around 35 weeks. We swab the vagina and the rectum. You can sometimes also test it through the urine of mom to see if that at this moment she's positive. Because if she is, we need to treat mom with antibiotics during labor to protect the baby from contracting this strep and causing potentially a sepsis or a meningitis in the newborn. So gestational age of the infant. So we're talking about full term versus preterm versus post-term. So a full-term infant is born between the gestational age of 38 completed weeks and 42 completed weeks, meaning that we do not round. So an infant who is 37.6 weeks, meaning 37 weeks and 6 days, is not a 38-weeker. They're still just a 37-weeker because they haven't completed that entire week cycle. So they have to make it to exactly 38 weeks to be considered full term. So we say between 38 and 42 weeks is what we call a term infant. Notice 42 weeks is 2 weeks after 40 weeks. So oftentimes people think because you go past your due date, which is around 40 weeks, that you're post-term, but you're not. You're just post-dates, meaning you're past your due date, but you're still within that full-term category. Now, oftentimes full post-dates and post-term are used interchangeably, but there is a difference to them. A preterm infant is an infant born prior to 37 weeks of gestation, regardless of their birth weight. So oftentimes parents will refer to their infant as preterm because they were small when they were born, or not preterm because they were really 36 weeks, but they were 7 pounds, so they don't really consider them preterm. They are. It has to do with gestational age and not of weight. And then post-term infant is an infant that's born after 42nd weeks of gestation. So again, often interchangeable with post-dates, but it's not. Post-term means after the 42nd week. So this is just a gestational age and weight chart that we use to plot them to see if they are appropriate size for a term infant. So again, remember, you can have a preterm infant, so less than 37 weeks, that just happens to be a bigger baby. You can also have a term infant that happens to be very small. So you could have a baby born at, let's say, 39 weeks, but they happen to be 5 pounds. So that doesn't, remember, weight and gestational age are not the same thing. So we graph these babies based on if they're term and where they fall in categories as far as their weight and their length and their head circumference tells us if they are small for their gestational age, if they're appropriate size for their gestational age, or if they're large for their gestational age. So AGA is appropriate for gestational age or average for gestational age. So these are infants with a birth weight for their gestational age that falls between the 10th and the 90th percentile. For anyone who has children, they know that they graph this initially, and then every time they go for checkups, they will do this chart to see that they are adequately growing at the weight that's appropriate for how old they are. So this starts at gestational age. If they are small for gestational age, these are infants that birth weight is less than 10%, or the 10th percentile for that gestational age. And for babies who are in that large for gestational age, this is their birth weight is greater than the 90th percentile for their gestational age. So when we talk about term versus preterm infants, we're going to talk about some differences here. Just by looking at this picture, you can see so many differences, right? You can see that the head to body ratio on the preterm infant the head is much greater. So the head is initially bigger as a preterm infant to their body ratio. You can see the skin, the color, obviously redder for the preterm than the term infant. It's also more sticky, friable, shiny. You can see that this infant, the preterm infant, does not have any hair, including no eyebrows. You can even see the ear is hardly formed on this preterm infant. You can't even hardly make out the delineation of the pinna. The flexion of their legs they're elongated and kind of laying there flaccid, as opposed to the flexed position on the term infant. You can see that their breast areola is not evident. So where it is on the term infant, you can't really see it on the preterm infant at all, and I guarantee you don't feel a breast bud there either. Genitalia wise, obviously the scrotum is not hanging. There's no real delineation of where the penis or the scrotum is on that infant. So this is just kind of a picture when you're doing that ballot exam to kind of have in your head of what we're looking at when we talk about lanugo, when we talk about ears, genitalia, skin color, when we talk about creases on the feet, this posture, this is everything that we're looking at. So next we're going to talk about the skeletal system of the newborn. So at birth, babies will have more cartilage than they actually have ossified bone. So infants often look out of proportion. This is called cephalocaudal head to rump development. So extremities should be symmetric and should be of equal length. We can do something called an Ortolani's or a Barlow's maneuver, where we check to make sure that the hips are developmentally placed, that there's no developmental dysplasia. So we would stand the infant up to look for any asymmetry in the thigh and the gluteal folds, where one leg looks shorter than the other, and that could indicate that the hips are not developed all the way. Or we can abduct the legs while the baby's laying in a supine position, listening for a hip click. This will tell you if there is a hip dysplasia or a hip that's out of place in those sockets. Because the bones are more ossified, more cartilage than they are ossified, they're softer. So it's easier for those hips to kind of come out of the socket because they're soft. As time goes on, that'll become more ossified bones, and obviously they'll be harder in place, but they are less of an ossified bone because they need to be softer in order to kind of accommodate that birth canal and come through. So during that time, especially if they're a baby who's born earlier, that's not uncommon for their hips to kind of come out of the socket, if you will. So we want to make sure that we count their fingers and their toes. A polydactyl or a syndactyl, poly would mean they have an extra finger or toe, and a syndactyl would mean that they're missing a finger or a toe. So a polydactyl is not super uncommon, and it's very hereditary. So oftentimes if a baby is born with an extra finger or an extra toe, one of the parents had that same symptom at birth as well. We find that there's a big familial trait with that. If they do have an extra digit, it's an easy fix. So they can either they normally will kind of tie a suture around that finger or that toe to cut off circulation, and eventually that extra digit falls off, especially if there's no bone formation. It's often just skin, or they can surgically remove it. If a baby is born without a finger or a toe, that's called syndactyl, where they're missing one, and obviously there's no fix for that. If they don't have it at birth, they will never have it going forward. And that can be caused by something called amniotic band syndrome that we'll talk about later in high risk, or it can just be a genetic malformation. We also want to look at the creases of their palms and their soles too. When we're looking at their head, we're looking at fontanelles. So babies have two fontanelles. They have an anterior and a posterior fontanelle. The anterior fontanelle is located at the intersection of the sutures of the two parietal bones and the frontal bones. It is a diamond shape, so you can kind of see that where that kind of forms a diamond. It's about 2 to 3 by 4 centimeters if you measured it across. This will close in about 18 to 24 months. So in that fontanelle, that's a soft area where eventually the bones will come together and completely close as a skull, but it takes about 18 to 24 months. And that's pretty easily felt when you are assessing that. That fontanelle should be smooth and it should be flat. So if it is sunken in when you're feeling it, that can indicate a dehydration in baby. And if it's bulging, that can sometimes indicate some intracranial pressure. However, I will have you note that if a baby is crying really hard or pooping really hard, they can bulge that fontanelle temporarily while they're doing that. A posterior fontanelle is located between the sutures of the two parietal bones and the occipital bone. This is more of a triangular shape, although it is so tiny that sometimes it feels like a circle when you're feeling it with the tip of your finger, but it is a triangular shape. And this closes much sooner than the anterior fontanelle. This will close about 6 to 12 weeks. We want to make sure that we're measuring the baby's head circumference. So this is important for all sorts of things. It's important when we're doing their gestational age and we're charting them on that graph to see if they're appropriate for their gestational age. It also will tell us if they're having any intracranial hemorrhaging, like that subgaleal hemorrhage. We want to make sure that we're measuring that head circumference, that it's not getting bigger. We know that the head is about 2 to 3 centimeters larger than the chest at the time of birth. That is a normal finding. Again, unless you have a preterm infant where the head is much larger than the chest and the rest of the body. We want to make sure we're assessing their respiratory system. Type of birth, there is whether it's a C-section or a surgical birth versus a vaginal will affect their breathing and how effectively they clear their lungs, if they had that benefit of that thoracic squeeze or not. Their initial breath is a reflexive response due to the pressure changes and other stimuli. So they'll initially just reflexively breathe when that umbilical cord is cut. They breathe about 30 to 60 breaths per minute with some pauses. These are called apneic episodes, but they should not exceed 20 seconds during a deep sleep. So it's not uncommon that when they're in a deep sleep that they could stop breathing, if you will, for like up to 20-second period. This is typical as they're transitioning breathing, but it should not last longer than 20 seconds. And then they should normalize about 30 to 60 breaths per minute. We know an infant is having respiratory distress if they are showing signs of nasal flaring, intercostal or subcostal retractions by the chest, grunting or gasping of air. There's something called seesaw or paradoxal respirations instead of normal abdominal breathing. So normal abdominal breathing is that their chest and their abdomen will rise in synchrony. So their abdomen and chest will rise together as they're breathing. This is typical of a newborn breathing. However, seesaw breathing or paradoxal respirations are when the chest rises, then the abdomen, the chest, then the abdomen. That is a major sign that they are having respiratory distress. Now, keep in mind that the nasal flaring, the shallow retractions, and a little bit of grunting can be common that first hour or two during that transition period right after they're born. Remember, we called that transient tachypnea, and they might be having some issues adjusting to extrauterine life. We give them the benefit of like an hour to see if they can kind of work out those kinks, if you will. If they're continuing to do it beyond that time, then they are definitely having some issues with respiratory distress. We have to remember that certain things can cause respiratory distress outside of their gestational age or the delivery. The analgesics or the anesthetics that were given to mom can depress respirations. So think of things like, was she put under a general for a C-section, which is not common, but if it happens, that could definitely depress their respirations. Was she given a medication like a morphine that can depress respirations? Was she given an epidural? Was she given a medication called magnesium sulfate that we often use for different reasons in labor and delivery, which we'll discuss later? That can cause respiratory depression. So we want to make sure that we're thinking about these things once the baby's born. Is there anything mom was given during labor that could be affecting how this baby is transitioning and how this baby is breathing? We want to look at the pulmonary lymphatic system and how they're clearing fluids. They can have something called meconium aspiration or congenital hernia or their gestational age that can compromise respiration. So we can talk about these more as time goes on. The congenital hernia and things like that we can talk about in the high-risk newborn. We'll talk a little bit about meconium aspiration in a few slides as well. This is when the baby has a bowel movement in utero and the baby then aspirates that amniotic fluid that has that meconium or that stool, if you will, inside that fluid. And when they aspirate it into their lungs, that meconium can kind of stick to their alveoli and obviously cause it to not expand properly. And this can cause some respiratory issues. But we'll go over that more in some further slides. Typically for a respiratory system, the fetal lung development is initially filled with fluid. We talked about how surfactant begins around 24 to 28 weeks. I think I said 25 in that previous slide. Again, when you go from book to book or different slides, you're going to see that there's a variance. If you see that there's kind of a difference in it, I will note it for you when you're taking your test. So like in this slide, we'll say surfactant begins around 24 to 28 weeks. They usually say an average about 25 weeks, and it does peak at about 35 weeks. So just so you're aware. It is the establishment of breathing after birth, and this is what allows the alveoli to open by mechanical and chemical and thermal sensory stimuli. When we talk about the cardiovascular system, we're talking about once we've cut the cord, which is the cord has those umbilical arteries in that vein, they will close. This will allow oxygenated blood to pass directly to the fetal heart. Within the first few breaths, now there's oxygenated and non-oxygenated blood are separated because before they weren't, and the apical pulse is heard. You can hear what's called a transient murmur initially, which is not uncommon. It's as those ducts are starting to close. Remember, they functionally close right after birth, but they haven't permanently closed. You can hear a murmur as that blood is swishing through those slightly open shunts, if you will. And so it's not uncommon to hear a murmur. If you do hear one, you do have to note it. There are some protocols that hospitals will do where they'll do blood pressures on all four extremities on the infant to make sure it is not a cardiovascular or a congenital defect and more just a transient murmur. But we can talk about that later. But just something you would note. We don't often or normally take blood pressure on a normal newborn. So you don't see this done in a normal newborn nursery. However, they do take blood pressures in the NICU. So if they were to take a blood pressure, the systolic blood pressure should be between 60 and 80, and the diastolic should be between 40 and 50. So it's not usually assessed again unless they're in the NICU or unless you heard that murmur. And then we're going to talk about something called a CCHD test, which is a newborn screening that shows the discrepancy in pulse oximetry between extremities to see if there's a circulatory issue going on. It also is a test to see that those shunts or those ducts have closed. So we'll talk about that here in a little bit. Oh, actually right here. So the CCHD is the critical congenital heart defect or disease. So this is a test that identifies defects that cause serious or life-threatening symptoms and require interventions within the first few days or the first year of life. It is a non-invasive test that we do to measure how much oxygen is in the blood, and we do it with an SpO2 monitor, and we measure in 2 different extremities. So this test is usually done after the first 24 hours of life because it takes about that long for those ducts to functionally close. We don't even test it till after 24 hours. Some hospitals will do it right at 24 hours. Some hospitals will do it on the day of discharge. Again, it's different protocols for different units. So we're going to put this SpO2 monitor on 2 different extremities, a preductal extremity and a postductal extremity. So the extremity where the blood flow is before it goes through the ducts, and an extremity where the blood flow is measured after it goes through those ducts. So the preductal extremity is always the right wrist. So we're always measuring the right wrist for our preductal extremity. The postductal extremity can either be the left wrist or either foot. Preferably the feet because it's the furthest from the arms, and so we can really get a better view of how that blood is completely circulating, but that's normally how it's done. We look for abnormal or absent heart chambers or holes in the heart, abnormal connections in the heart, abnormal functions in the heart, or abnormal failure of those ducts to close properly. So any of those would be evident or would be suspected if they have differences in these So normally the findings for that CCHD test, we're looking to make sure that the extremities, both extremities, the preductal and the postductal, are over 95% for their oxygenation, and that there's less than a 3% difference between a preductal and a postductal extremity. So that is the common findings we're looking for. If that occurs, if it's over 95% in both extremities and there's less than a 3% difference between the 2 extremities, then we know that those ducts are closing properly, like they should. There's also some conditions which are in here where there's abnormal heart connections and abnormal functions of the heart, that if the ducts close like they're supposed to, it can then cause issues for the newborn who was kind of relying on those ducts to stay open during the cardiovascular system. So this could also identify that if there's abnormal heart issues, that would be identified as this as well. The next thing we're going to talk about is the renal system of the newborn. This is developing the baby's kidneys, and it's starting to produce urine by about 9 to 12 weeks gestation. So babies are producing urine quite early during the gestational period. The newborn will usually urinate within the first 24 hours after they're born. The kidneys become able to maintain the body's fluid and electrolyte balance. The rate at which blood filters through the kidneys, or the glomerular filtration rate, is increased sharply after birth and within the first 2 weeks of life. It takes a little time for the kidneys to get up to speed, so they're not fully functioning at optimum rate initially at birth. It takes a little bit of time. And newborns have less of an ability to remove excess salt or sodium, or to concentrate or dilute the urine compared to adult. This will improve over time as well. Initial urine of the newborn is cloudy and can have scant amount of uric acid crystals, which can look like a reddish stain on the diaper, but it is normal. The urine pH ranges from about 5 to 7, and their low specific gravity ranges from 1.001 to 1.020. That you do not have to memorize. When we're looking at the diaper of the newborn, newborn babies will usually urinate between 4 to 6 times a day in the first few days of life. We want to make sure that we're teaching families to observe diapers. So we want to make sure that they're getting enough in and that they're adequately urinating by how often they're changing the diaper. So a wet diaper is a good thing. So we want to make sure that we're teaching families to make sure you're keeping count how many diapers you're changing initially in those first few days. Newborn babies are about 75% water, which is the highest proportion of body water at any stage of life. So this is the time of their life that they'll have the highest proportion of water compared to the rest of their body. When we look at the hepatic system, we know that the fetal liver acts as a storage site for sugar. So this is called glycogen, and they store iron. So when glucose is being produced in utero, infants will produce that glucose, but they'll store it in their liver as glycogen. After birth, it produces substances to clot the blood, and to break down the waste products, which is that excess red blood cells. And this is a protein that produces to break down bilirubin. So this is how the liver is used. It's used to store the glucose and the iron, and it produces the substances that help clot the blood. And it also produces something to help break down those excess red blood cells. If the baby's body does not properly break down bilirubin, this is newborn jaundice. So the liver is immature initially, which is why it's not uncommon to have a newborn jaundice, because the liver is not really perfectly effective at breaking down this bilirubin and to excrete it. And so this is why that bilirubin builds up in the newborn and why it's not uncommon to have newborn jaundice. The immune system is developed in the fetus. It matures throughout the child's first few years of life. The newborn will carry antibodies in it from the mom. So they get passive immunity from their mom called IgGs for the first 3 months of life. This will be reduced if a baby is born premature. So obviously throughout the whole gestational age, mom is passively giving them immunity. They're giving them these IgGs, which will carry them for the first 3 months of their life. So if a baby's gestational age is interrupted by being born before they were term, they will have less immunity and less IgG because they didn't have the time for mom to pass that immunity on. Newborns receive antibodies from their mom's vaccinations as well. So if mom gets a flu vaccine, a pneumonia vaccine, a Tdap vaccine, which is tetanus, diphtheria, and pertussis, babies will receive the antibodies from those vaccines as well. So we encourage mom to get those vaccines, or we recommend them to get those vaccines while they're pregnant so babies can receive those antibodies as well. Breastfeeding is another way for babies to get immunity. So this is a passive immunity that they get from breastfeeding called IgAs. And this gives neonates an overwhelming advantage over artificially fed babies or bottle-fed babies. So breastfeeding protects babies by reducing the odds of SIDS, that's sudden infant death syndrome, by 36%. It increases it decreases the likelihood of allergies. It actually has been found to boost intelligence. It's also found to reduce adult and childhood obesity and diabetes. So there's lots of research done that breastfeeding is best. And this is basically because of all the overwhelming, vitamins and nutrient rich that comes in the breastfeeding, but also those IgAs that they're passing to their babies with this immunity. It can set up that normal flora bacteria, that gut bacteria that's in babies' guts for the rest of their lives. So hematological system, we're looking at the high red blood cells that are normal in the newborn, 4.5 to 7, their hemoglobin, their hematocrit. Their white blood cells are about 18,000 at birth, and then with relative neutrophilia. Remember, their coagulation is dependent on that vitamin K clotting factors, and remember they're decreased, which is why we give them that vitamin K initially. And then their platelet count is between about 150,000 and 350,000. You do not need to memorize these values. Just so you know, this is just an informational slide. The characteristics of those high red blood cells are essential to provide adequate oxygenation in utero and during the first few postnatal days before the lungs fully expand. So that is the reason why babies have a higher concentration of red blood cells, because it's essential for them to get oxygen since they don't have fully functioning and expanded lungs yet. The fetal red blood cells are large, so they can have lots of O2 capacity to carry those oxygen, but they are short-lived. They only last about 80 to 100 days versus lasting 120 days in adults. So this is how jaundice plays a role. Jaundice is increased bilirubin in the blood. So newborns break down their excess red blood cells, because remember they have a lot of them, at a fast rate because they're short-lived. And bilirubin is the byproduct of the breakdown of red blood cells. So they have a lot of red blood cells, they're breaking down rapidly because they don't live very long, and bilirubin is the byproduct. So you can see where we're going with this. All this bilirubin is being built up in their system. It is also processed in the liver and excreted in the urine and stool, which we've also just learned that the liver is not 100% effective at first either, so it's not doing this at a very effective rate. So the total serum above 5 is cause for further assessment or treatment. So we really want the first 24 hours of life, their total serum bilirubin to be below I would say we want it to be below 6. Some hospitals will say 5, some hospitals will say 6. Again, depends on different protocols of different hospitals. However, if it is higher than that, this is a cause for possible further assessment, observation, or treatment. And it is the most common reason why newborn babies are readmitted into the hospital is because of bilirubin. So there are different types of jaundices. There's the first one we're going to talk about is a physiological jaundice. This is caused by transient hyperbilirubinemia, meaning that just a small amount of time where there's an excessive amount of bilirubin in the blood system causing this physiological jaundice. This is your typical, most common type of physiological or most common type of jaundice. It's due to the fact that those red blood cells are breaking down rapidly, that their liver is immature and it's not, conjugating that bilirubin quick enough. And the fact that they're just starting to eat and drink and pee and poop and they're trying to excrete that excessive bilirubin, but they're not doing it rapidly. It usually will appear within between the second and the fourth day of life. So we don't see it initially, but it'll start to progress about the second to fourth day of life. It appears more when the level is above 5 to 6. So we just talked about how that's the level. So meaning that you don't necessarily see the yellowing of the skin till it reaches those levels of 5 to 6. And again, it is due to the immature liver effects that process and eliminate that bilirubin in the newborn system and the excessive red blood cell breakdown. So that is typical physiological jaundice. A pathological jaundice is slightly different in the fact that this will occur within the first 24 hours. So the first one occurs about the second to fourth day of life. This is the first 24 hours. Bilirubin levels rise much more rapidly and they rise to a much higher level and they stay elevated much longer. So whereas the physiological jaundice will rise about the second to fourth day, it will also start to descend on its own, usually without treatment, as long as the numbers are relatively lower, and it will kind of go away on its own. Where this pathological jaundice will rise very, very quickly within the first 24 hours at a much higher level. You won't see those 5s and 6, you might be seeing 8s and 9s and 10s, and it'll stay elevated, usually requiring treatment. This is due to the excessive destruction of red blood cells or problems with bilirubin conjugation or breakdown. So what can excessively destroy red blood cells? So we know that red blood cells are getting destroyed normally, naturally, because there's a lot of them and they have a short life. So that's not excessive. Excessive would be things due to an ABO incompatibility, which we'll talk about here, infection, metabolic disorders, trauma, or damage to the red blood cells. So let's talk about trauma or damage. That would be like a baby who was bruised during delivery, either a very tight squeeze through the birth canal, or maybe it was harder to get the baby out via C-section and they were doing a lot of pulling and pushing on the baby and they were causing damage to the red blood cells, which is bruising. So if you had a baby with a lot of bruises, we know that they have had trauma or damage to those red blood cells in excess of what they normally would, and this can cause a pathological jaundice. So when we talk about probably the most common reason for the pathological jaundice is the ABO incompatibility, and that has to do with blood types. So if the mom is an O blood type and the baby is anything other than O, so the baby is an A, a B, or an AB, and in this case we don't really worry about whether they're positive or negative, we're just looking at the actual blood type. If the baby is anything other than O, there's an incompatibility between the two blood types. And what will happen is mom's O blood type will make antibodies against baby's foreign, if you will, blood type, which is the A or the B or the AB. And those antibodies will attach to the baby's red blood cells and cause excessive destruction or breakdown of those red blood cells. So that occurs, again, mom's blood type, which is incompatible with babies. So mom has to be an O and baby has to be an A, a B, or an AB. Mom will make antibodies. Those antibodies can attach to baby's red blood cells. And those once they're attached to baby's red blood cells, they cause an excessive breakdown of those red blood cells, causing an increased amount of bilirubin to be in the blood. And that causes that pathological jaundice to rise very, very quickly due to that. So we test this by using what's called a Coombs test. So we detect antibodies that act against the surface of those red blood cells. And we also test for the presence of these antibodies, which indicates hemolytic anemia, in which red blood cells are destroyed prematurely or at an excessive rate. So there's two types of Coombs test. There's a direct and an indirect. So the direct Coombs test will test for antibodies that are attached to the surface of the red blood cells. So this is a test done on babies. We're looking specifically for, did those antibodies attach to the surface of the baby's red blood cells? So that's a direct Coombs test. An indirect Coombs test is something that we test mom for to see, does she have antibodies in her bloodstream created looking for a place to attach? So mom will, did she start to create these antibodies? We want to know that. And are they in her bloodstream? That's an indirect Coombs test. And then if those antibodies did find a red blood cell surface to attach to, then we would find that out by directly testing the baby on a direct Coombs test. Another type of jaundice that can happen, but is not as common, is called breastfeeding jaundice. And this can occur within the first week of life. And it's most commonly caused from insufficient intake, so poor breastfeeding. So babies who are sleepy or have a poor suck or latch or do not breastfeed adequately, they're not receiving enough colostrum, which has this laxative effect that helps them eliminate the bilirubin-rich meconium. And so that can cause an increase in bilirubin because they're not excreting as much. So if a baby's not taking in as much, they're not excreting as much. And it's more common in breastfeeding than in bottle feeding, because if you're bottle feeding a baby formula, they're getting whatever's in that bottle. But if they're breastfeeding, which we're going to learn here in a little bit, it's a lot more work. They have to be able to latch properly, suck properly, get that colostrum in. That colostrum has to work through their GI tract in order for them to eliminate the bilirubin, which is contained in that meconium, and then they need to be able to poop that out. So a baby's GI system doesn't fully function right after birth. Okay, so it's another system that's taking a little time. In late pregnancy, the fetus produces a tarry green or black waste substance called meconium. Meconium is composed of several things: amniotic fluid, mucus, lanugo, bile, and cells that have been shed from the skin and the intestinal tract. In some cases, the baby passes the stool while still in uterus. So this is what we talked about, that meconium aspiration. So the baby can have their first bowel movement while they're still in utero. And if they do, that meconium is now mixed in their amniotic fluid. So normally, when a baby is born and they take that first breath, if there's nothing but clear amniotic fluid, a baby can actually breathe that in and that'll dissipate right in their lungs. It's not a problem. But if meconium is mixed in that and they do breathe that in, that meconium then can be aspirated into their lungs, stick to their alveoli, causing them to not expand fully, and this can cause respiratory distress. We know that sucking is a reflex that becomes coordinated around 32 weeks. This is why it's difficult, or one of the reasons why it's difficult to feed a preterm infant. They do not have a proper suck reflex. We know that the bowel lining is protected by the IgAs that were passed from mom to baby through the colostrum. And it's what can trigger allergies if you don't have this protective lining. So this is another reason why breastfeeding decreases the likelihood of allergies, because of this protective coating they get from the IgA passed in the colostrum. Colostrum is thick and yellow, and it is super concentrated with 100% digestible proteins and antibodies. It also has a laxative effect to it, which helps them move their bowels and excrete that meconium initially that has that conjugated bilirubin in it, so they can eliminate it and get rid of it, and it doesn't build up in their system. Infants often regurgitate easily because they have an immature cardiac sphincter between the stomach and the esophagus. So it's not uncommon for them to regurgitate their feeds, both breast and bottle feeding. It's not vomiting. That's different, and that would be abnormal. Regurgitation is just basically spitting up a little bit after feeds. So when we think about the size of a newborn stomach, this is a visual representation of really how small their stomach are initially. So on day one, their stomach is only the size of about a cherry. So you can see the small amount of can either be expressed breast milk into a bottle or formula that the baby should be getting per feed. On day 3, it's more the size of a walnut. By 1 week, it's the size of like an apple, apricot, size around there. And about a month of age, it's about the size of an egg. So that's how you can kind of get a visual representation of how much formula or how much breast milk they should be getting at each feed. When we talk about the reproductive system, in the female, they should have external genitalia that can often be edematous. And this has to do with the increased estrogen passing from mom to baby. So their labia can look swollen. It's not abnormal. It's not uncommon. It's just that extra estrogen that's being passed from mom to baby. The levels will drop near birth, which causes a discharge or spotting of blood. And the labia covering, we know, can indicate maturity. We already talked about it in the Ballard score. The more it's covering the clitoris, the more mature they are. The spotting of blood can be what we call a pseudomenses, which just has to do with the decrease or the level drop of estrogen that's passing through them. And sometimes they can have spotty blood that you might notice in the diaper, and that can be normal. In the boy babies, the testes will descend into the scrotum in about 90% of our term infants, and the position of the scrotum changes with the gestational age, as well as the rugae, or the amount of wrinkling in the scrotum. Breast tissues may be swollen on either gender because of that hyperestrogenism of pregnancy. So remember, there's a lot of estrogen in pregnancy being passed from mom to baby. This can cause the newborn to have swollen breast tissue temporarily, and could be in either the boy or the girl baby. In the neuromuscular system, the mature newborns are demonstrated by their neuromuscular functioning. Can they move their extremities, attempting to control their head movement, exhibiting a strong cry, demonstrating newborn reflexes, involuntary muscular responses? The newborns will occasionally make a twitching or a flailing movement of their extremities in the absence of stimuli because of their immature nervous system. So infants will often twitch or move. It's not shivering, it's not a startle reflex, it's just an immature nervous system and how they can react. Parents often will confuse this movement as a shiver, as if the infant is cold. Remember, infants don't shiver. They don't have a shiver mechanism, and it's not a reaction to being cold. It's just an immature nervous system. The different newborn reflexes that babies are born with are a blink reflex. So if you were to flash an object toward their eyes, they will blink. Their Moro reflex, which is a startle reflex, which they make this C-like formation, an embrace-like reflex when they kind of pull their arms in and their knees up when they're startled. A grasp reflex is a protective reflex by putting something in their hand and them grasping it. There's a stepping reflex where if you were to kind of hold the babies up under their arms and kind of let their legs dangle and you touch parts of their foot, they can alternate their extension and flexion of their foot and kind of mimics that they're stepping. There's a tonic neck response, which gives them a fencing position, and we'll go over these in the future slides. There's a sneeze reflex, which helps them clear any kind of debris in their nasal passage. It's not a cold, they're not sick, it's just because they can't obviously blow their nose, it's how they get rid of the irritants. There's a rooting reflex, which is a breastfeeding reflex that helps them open their mouth to get to the breasts. There's a gag reflex and a cough reflex. Obviously, those help prevent choking. And then there's a Babinski reflex that we do on the foot. So these are the different reflexes. The grasp reflex is when the touch of the palms or the soles of the base of it makes the digits grasp, which is normal. So if I touch the base of the hand, the fingers will grasp around, just like that baby's grasping onto something there. And if I touch the base of the foot, the toes will curl around or grasp. That's the grasp reflex. These are crawling, tonic neck reflex, rooting, suck, and swallow. These will all assist with self-attachment and feeding. So we're looking up at top at that crawling reflex, where if you kind of put their knees up, they'll kind of push off and mimic a crawl. That top picture to the right is a rooting reflex, where if you stroke the baby's cheek, the baby will turn toward the side of the stroke and open their mouth. That's a good way to get them to latch on for breastfeeding. The bottom left picture is the tonic neck reflex, where if you turn the head to one side, they do this fencing-like position. And that bottom right picture is the suck reflex, that if you touch the posterior part of their tongue, they will start to suck. So remember, it has to be the posterior part of the tongue, and we'll talk about that in a moment. There is a Babinski reflex, which is stroking the outer lateral edge from the heel to the ball of the foot. A positive means that the great toes dorsal flex and all the toes fan out. So if you stroke the side of their foot with your finger, you can go ahead and see those toes fan out. The Moro reflex under that neuromuscular tone allows the head and the trunk to fall, supported by back fingers that form like a C. So this is that reflex startle where they kind of bring those arms together in like a C-like formation. The sucking reflex. So this is when a newborn's lips are touched and the babies make a sucking motion. So you take your gloved pinky finger and you put it into their mouth and you kind of elicit that by touching their lips and touching the back posterior part of the tongue, and it will elicit a sucking reflex. This helps a newborn find food when the newborn lips are touched, when the mother's breast touch the mouth, as well as when the areola is pulled back and touches the back of the tongue. It allows that sucking to take place and they take on food. This will begin to diminish at about 6 months of age, meaning that they're going to continue to feed. They're going to continue to suck, but it's no longer a reflex, but a learned motion. So this is just a reflex that you don't have to teach them how to do for about the first 6 months. And then after 6 months, it's just a learned motion. The blink reflex, we talked about shining a bright light in their eyes or clapping near their eyes. The infant will close their eyelids. The swallowing reflex is that when food reaches the posterior portion of the tongue, it'll automatically be swallowed in. And the gag, cough, and sneeze reflexes are all ways to maintain airway in the event that normal swallowing does not keep the pharynx free from obstructing mucus. So this is just those reflexes that prevent them from choking on things. The extrusion reflex is that the newborn extrudes any substance that is placed on the anterior portion of the tongue. So this is where it's important to remember the difference between extrusion and suck reflex. So this is a protective reflex that prevents them from swallowing inedible substances. So this prevents them from swallowing or choking on anything. So if I were to give them a medication like Tylenol, which we often do for like a newborn baby who's had a circumcision or maybe a baby who has a fever, if I take that dropper and I place it on the top of their tongue or at the tip of their tongue, they're going to push it right back out. So when we administer medication to infants, we have to make sure we're getting to the back portion of their tongue. And so remember, when we touch that back portion of their tongue, they're not only sucking, but it elicits the swallowing reflex. So they get that medication down. If I only did the medication at the tip of the tongue or at the front of the tongue, they're going to push it right back out. That's that extrusion reflex. This will disappear in about 4 months of age. But it's important to remember that they have this reflex when you're giving them medication because they will just push it right back out. There's overwhelming evidence that breastfeeding is one of the least expensive, healthiest, and safest options for feeding a newborn, but there's many factors that come into play with this. So there's different choices on why a woman chooses to breastfeed or not, and we need to support her in her role if she chooses, whichever way she chooses to feed. So your role is to provide sound evidence-based information, but not to be judgmental. And research has established that patients listen to nursing instructions on feeding practices overwhelmingly over what they read, over what friends say, over what doctors say. There's a strong connection in the nurse-patient relationship and what they're listening to as far as instructions on feeding practices, how to do it, and reasons why you choose different things. So the American Academy of Pediatrics provides guidelines for infant feeding, and they advocate exclusive breastfeeding for 6 months. So nothing but breast milk for the first 6 months is what they advocate for. The AAP recommends that it be continued for at least the first year of life, meaning that after 6 months, you can introduce things like cereals or maybe juices, but that you continue breastfeeding until at least the first year of life. That's their recommendation from the American Academy of Pediatrics. So how do we assist in baby-friendly standards? Well, every labor and delivery, postpartum unit, nursery will have a written policy that's communicated to staff. We educate all our staff on how to make it more baby-friendly. We inform all women and families of options and the different evidence-based research that shows that breastfeeding is overwhelmingly the most effective. We show all new moms how to initiate and maintain breastfeeding. So we show them techniques and positioning, and we give them guidance. We give newborns no other food or drink besides breastfeeding if this is what moms choose to do. So we do not supplement with formula unless it's medically necessary. We encourage moms to do what we call on-demand feeding. So rather than follow the clock and say you need to feed your baby every 2 hours or every 2 to 3 hours, we tell them, look for your baby's cues that they're hungry, and there are cues that babies will give. They will turn their head from side to side. They will do that rooting reflex where they'll open their mouth. They'll bring their hand to their mouth. Those are all early signs that they're getting hungry. By the time the babies are crying, that's a late sign of hunger. And sometimes it's difficult to get the baby to calm down enough to actually latch and breastfeed because they're already now so starving, if you will, so hungry that they're crying, and it's difficult for them to calm down in order to do effective breastfeeding. So you really want to teach them to recognize those early breastfeeding cues so that they can get them when they're in that calm state and they can effectively breastfeed. This is important practice in what we call in-rooming, or practice 24-hour access to babies. So a lot of hospitals have moved from babies going into a nursery to babies staying with their moms basically 24 hours a day. And part of this was so that you can learn these cues of your baby and that you can effectively breastfeed if that's what you're choosing to do so, because you're with your babies all the time and you can learn what cues your baby gives that they're hungry, and you can feed them immediately at those times, and it's not delayed. So you're not getting your baby who was in the nursery for the last 3 hours now in a screaming fit, and the nurse comes to you and says, okay, this baby's screaming, it's really hungry. Well, you may have been able to catch that an hour beforehand when they were giving that early cues, and you could have done maybe better and more effective breastfeeding at that time. We also, baby-friendly hospitals do not give pacifiers until breastfeeding is well established. So that's also a baby-friendly standard, that if you do choose to breastfeed, we do recommend no pacifiers until you've established good breastfeeding. And that really usually takes about a month to establish good breastfeeding. And then we offer breastfeeding support groups. So most hospitals you see will have lactation consultants, lactation breastfeeding support groups. They'll have hotlines. There's lots of different things we do to support our moms who are trying to breastfeed. If your mom chooses to bottle feed, we want to make sure that parents know that there is definitely a difference. There's a difference in both the nipple shape and the rate of the flow of the milk from the nipple. That mother-infant contact is really important, even during bottle feeding, to do that on-face bonding while you're bottle feeding the baby. And we have to let them know that there's importance in how we mix the formula, the temperature of the formula, the water supply. We want to avoid the lead and the plastic in certain bottles, and there's different positionings for bottle feeding as well. So when we're teaching effective bottle feeding to our parents, what will we do? Well, we review that there are different types of formula. There's cow or soy or specialized formula. We talk to them that normal formula, that when they're formula feeding, they should get about 100 calories per kilogram per day, and they should do about 6 feedings a day for at least the first 4 months. We tell them that this is time for them to relax, smile, stroke, snuggle, bond, do that on-face eye contact. We tell them that they never microwave bottles to warm them up because it can give them hot spots that can burn the infant. We tell them to discard any formula that's not taken in within that first hour. So if they are formula feeding a baby and the baby takes longer than an hour to eat that formula in the bottle, or it's been longer than an hour, maybe the feeding was disrupted by something. Like if they're in the hospital, maybe it was disrupted by a procedure. If it's been longer than an hour, they've established that bacteria can start to grow on the surface of that nipple in the formula, and that after an hour, you really need to discard any unused formula, and then you need to reopen a new bottle. And we want to make sure that babies are frequently burped during feedings, specifically bottle feedings. When you're bottle feeding a baby, they take on more air than if they're breastfeeding. Both babies require burping, but bottle-fed babies can take in formula and air at a much faster rate. And without proper pauses during the feeds and time to get the baby to burp, babies will easily vomit that or regurgitate that back up because they're taking in too much too quickly with all that excessive air. I usually recommend to my patients that they stop about every 1/4 of an ounce to stop and burp them. We want to make sure that we give our babies their initial bath. So when we're bathing a newborn, we wear gloves, because remember, anything on the newborn before their bath that's on the surface of their skin came from mom. So she could have potentially any diseases or infections that can be on the surface of babies. So you want to make sure you're wearing gloves. You always begin with the eyes and wipe that with a warm, wet cloth, no soap, and the face area as well. And then you work from head to toe then, ending with the diaper area being the last thing. You want to wash them with baby soap, except for the face and the eyes. You rinse them and you dry each area as you go. So you don't want to keep them all wet and then all dry them. You want to kind of keep them dry as possible throughout the time because you want to prevent that evaporation heat loss. You want to make sure you get those creases and folds, specifically under their armpits and by their thighs, to make sure that, and behind their neck, sometimes they can have some creases back behind their neck. You want to make sure you're getting all that vernix and fluid that's caught between there. And you want to run the water for shampoo. You want to rinse it and then you dry it. To care for the umbilical cord, the umbilical cord will dry on its own and fall off between about 7 to 10 days. We first look at counting that cord. We look at the artery, vein, artery. That's what that AVA stands for. We want to make sure that they have 2 arteries and a vein. We want to make sure that the cord is not bleeding. We want to protect it while we're diapering. So we don't want to trap or pull that cord when we put a diaper on and cause tension on that cord. So oftentimes a newborn diaper will have a little notch cut out where the umbilical cord is, or you can just simply fold the diaper underneath that cord to prevent it from pulling on it. We remove our cord clamps that were initially clamped when they were first born. So remember, we clamp that cord with a cord clamp, and then we cut the cord between mom's placenta and the baby, and that's what separates it. That cord clamp stays on for about 24 hours. After about 24 hours, that cord is dry enough where we can remove that clamp and safely. And we want to teach parents that it's important just to kind of watch for signs and symptoms of infection. You would clean it like normally. It'll eventually dry and fall off in days to come. When we're talking about circumcisions, this is a picture of how they perform a circumcision, and that's removing that foreskin of the penis. So on the top, you can see that's the foreskin fully there. Initially, they're going to cut that skin to kind of separate it. Then they remove it around the outskirts of the penis, and that's what that circumcision looks like. So we want to make sure that after that circumcision is done, we're assessing for bleeding every 30 minutes for at least 2 hours, because that's, if there's going to be some bleeding issues, it's going to be usually within that first 2 hours. We want to make sure that we document that a first void has occurred after the circumcision. We put petroleum jelly on the penis as well as the diaper to help keep the drying blood from sticking to the diaper and then potentially ripping that off when you pull that diaper back. In that right-hand corner, you see this is called a Gomco. This is the tool they use to do the circumcision. It allows a gauge to kind of hold the penis up. It also allows you to put a protective bell around the head of the penis so you're not getting any of the glands. And it gives you kind of an area where you can cut around the foreskin safely. It gives you kind of like a marker to make sure that you're cutting in the appropriate direction and way and not too deep. And it also constricts the blood vessels with this Gomco to limit the amount of bleeding that occurs. Once the circumcision occurs, the penis picture at the very bottom of the slide is what it looks like. So it's bright red. The foreskin is now removed. This is where we're putting the petroleum jelly on, that as well as the diaper. It's going to look red like that for a few days. That is normal. It can have a scant amount of bleeding initially. That is normal as well. If it's excessive amount of bleeding, if it's like soaking through the little 2x2s we put on it initially, that can be a sign that it's bleeding too much, and that may require further care. So this is something that you guys will teach as postpartum nurses on how to care for the circumcision, signs and symptoms to look for as far as infection and excessive bleeding. Circumcisions are usually done by the obstetrician, because a circumcision needs to be done by a surgeon because it is considered a surgery. However, some pediatricians can do this as well, but most of the time obstetricians will do it. It's usually done the day after they're born. They like to make sure that the baby's had at least one void before they get the circumcision. They will often give them Tylenol afterwards for pain control. They will sometimes, depending on the doctor or the hospital protocol, they will give them lidocaine for numbing medication, and sometimes they will give them Emla cream. And this varies per doctor, it varies per patient request, it varies per hospital policy. Some doctors feel that the injection of the lidocaine is as painful as the circumcision themselves and don't feel like they need both painful stimuli, so they don't do the lidocaine. Some doctors will. I will say that a lot of times it is patient requested. A patient may say, I really want my child to have this, or I don't want my child to have this. This is usually done in discussion with the doctor who's doing the circumcision. The circumcision is usually done in the nursery under sterile procedure on a circumcision board where the doctor and the nursing assisting. The baby is watched in the nursery for about a half an hour or so, sometimes an hour, depending on the protocol. Initially, we're looking for that bleeding, and once we've established that the bleeding is a normal amount, we will take the baby back to the room and we'll give circumcision care, where we're teaching the patient what it looks like, the bleeding to look for, how to put the petroleum jelly on, how to watch it from there on up. We also talk about car seat policy and safety for the newborn. Car seat policy is often local fire stations can help you with placing your car seat properly into your car. We do not do this at the hospital site. So the car seat base should already be in place in your car and safely done either by you or by the help of a local fire station before you put the car seat in the car. We as hospitals cannot take that responsibility to adjust your car seat for you or to put it in properly because of liability issues. We also talk about abductions and keeping your baby safe from abductions. We talk about supervising your baby during the bath, that it can just take a few inches of water that a baby can drown in. We talk about safe sleep. So we advocate putting the babies on their back to sleep to prevent sudden infant death syndrome. So we go over all these different safety mechanisms that they'll will need to know. This is all part of that postpartum and newborn teaching. This is all part of what we give new moms and dads when they go home. And we're going to go into this a little bit further as we go into the clinicals and as we go into the slides on the newborn. But this is part of the safety things that we give instructions on. So that is the end of the newborn, the normal newborn. So on your schedule, you'll see that the first test includes both the first slide, which was foundations of women's healthcare nursing, as well as the newborn, the normal newborn and their systems. So this is part of that first exam. Now we're going to move on to newborn nutrition on the next lecture. Thank you.